So thanks for the invitation, and good afternoon, everyone. I know it's been a hectic morning. Um, the topic today is about avian flu. We had this conversation with Dr. Looker 3, 4 weeks ago. Do we want to go bird flu? Do we going to go measles? And we decided to do bird flu because we had a case, but we didn't have a case of measles. Sure enough, now we have a case of measles. So I'll see if we have time at the end. I'll try to say a couple of words about measles. But the main topic today is bird flu. I have no conflicts of interest, and we're going to try to understand what's the situation domestically and locally, and what is it being done to monitor where things are going, and try to explain you what we would like to see you guys doing on your end to help us what we may need to do if this gets into any major problem. And then, try to guess where this is going to go. So I'm going to start with an overall review of influenza, but only highlighting the aspects that you need to know. So even though this sounds technical, I think the better you understand this terminology, the less confused or the less intimidated you're going to feel. We all know influenza is a respiratory virus primarily, but it can also cause other symptoms, right? It can go to the brain, can cause kidney failures, can cause a bunch of other manifestations, thrombocytopenia, and so on. So it's not just confined to the respiratory tract like RSV is, but actually this is a systemic infection. There are 4 groups, major types of influenza, A, B, C, and D. Most of those who affect humans are A and B. C and D are rarely causes of human infection, and the others tend to infect other animals, right? Birds tend to have also a lot of group A influenza, but they affect them differently. The reason why humans and birds have different types of flus is because the receptors for the birds have are different than humans have, right? Humans have what is called the alpha-2/6 receptors, while birds have what is called the alpha-2/3 receptors. So 2 things there. One is they're different receptors. So in principle, what affects one should not affect the other. But number 2, there's not much difference between those 2 receptors. So it doesn't take too much in terms of mutations for a bird flu change into a human flu kind of receptor and then be able to affect and transmit among humans. Swine, pigs have both, so they can get co-infected with both, and that's a bad thing because then they can reassort and then they can become, from being a bird problem, become a human problem. Cattle, interestingly, they also have both, especially in their mammary glands, they have both receptors, and actually in the respiratory tract, they have alpha-2/6, but in the mammary gland, they have both alpha-2/6 and alpha-2/3, and actually the alpha-2/3, the bird one, seems to be more prominent, and that's why probably they get infected with this bird flu, and actually mostly in the milk. Now, how do a bird flu jumps into a human flu? Well, one is through single mutations, which obviously, as you can imagine, may take a lot of mutations after mutations until the wrong mutation happens to occur, and then they can jump from being bird flu to being human flu, versus reassortment, right? Reassortment means a rearrangement of the chromosomes, right? Flu, like some other viruses, it's not common, but some viruses have not a single long chromosome, but they have breaks, they have mini chromosomes. Flu happens to have 8 chromosomes. So if you put 2 flu strains in a culture medium, then similar to what happens when during mitosis in human reproduction, they will basically rearrange. And all of a sudden you can come out with a bird flu with the characteristics necessary to infect a human flu. So it's a way, evolutionary is a way to jump. Instead of doing little mutations at a time until you find the right or the wrong one, you just basically take a whole chromosome from a different type of flu, and then you become a new type of flu. This is, by the way, what happened in 2009, for those who can remember that outbreak. which was from swine flu, which again reassorted, infected pigs, reassorted into human, and then came back into humans, and then caused that pandemic in 2009. And that, which was an H5N1, is actually the prevalent flu that we have still this day. So it's like we are still living that pandemic, what is it, like almost 20 years after. So what I'm trying to emphasize is the versatility that flu has in terms of jumping from one type of animal to a different type of animal. And then the concept of H and N, there's many proteins in flu, but the two ones we use because they're to characterize them, because they're on the envelope, is the hemagglutinin, or H, and the neuraminidase, or N. There are 18 forms of H, and there's 11 forms of N, so you can have any sort of permutations. Humans, normally, the seasonal flu that humans normally get are usually H5N1 and H3N2 from the A. B is different. Well, birds get other types. They tend to get H5N1, which is the one that is causing the problem now, but also other types, H7, H9, and others. So it's not just one bird flu, it's many types of bird flu. There's not just one human flu, it's many types of human flus. And again, if they co-infect host, they can rearrange, and then all of a sudden you can have a completely new form. And then the concept of highly pathogenic, and lowly pathogenic avian influenza, they refer to birds, right? So the one that we're talking about today is a highly pathogenic avian influenza, which means that kills a lot of birds, right? That's not necessarily kills a lot of humans, but we know that they kill a lot of birds. And that's by itself a problem in terms of poultry and in terms of getting eggs and whatever. You heard about the price of eggs going up astronomically and all that, and it's a consequence of this problem. They don't necessarily mean they have to be highly pathogenic for human, but they can, and we'll talk about that in a moment. So putting all that together, the flu that we're talking about that today is a highly pathogenic avian influenza flu, which belongs to group A, and is an H5N1. And being more specific, because there's too many of this type, similar to COVID, that started as COVID and then became all these different variants and all these different subtypes. This belongs to clade 2344B, genotype B313. That's the one that is affecting cattle. But simultaneously, we're having an outbreak among birds with a genotype which is known as D1.1. And we'll get to those in a moment. This is what is called a phylogenetic tree. And I like it. I'm going to try to explain it to you because there has a lot of information in it. Came out in a very reputable journal, JID. And what it shows is a few things, right? So it basically, as you can see, all these lines represent different strains that have been happening, right? And the longer this line between the strains, the more different they are in terms of mutations, right? Their genetic makeup is different, right? Couple of things very important in this slide. One is the colors that tells you where these strains have been detected in the world, right? And then the timing at the bottom, right? So it tells you a number of things. Tells you, and as you can see, tells you that this problem started, H5N1 was first detected in 1995. So we're talking 30 years now, and it's been around throughout the world, mostly in the blues. So Antarctica, China, Southeast Asia, that's where it's been circulating for quite a long time. We haven't received much report lately for probably political reasons more than anything, but then extended into other parts, into Europe, into Africa, and all that, and continued. Then there was a jump here between being almost a single strain into multiple strains, right? And this is when it acquired the ability to jump from birds to mammals. So start to diversify in mammals, right? And then continue to diversify in mammals. And lately has come to the US, the red dots here, as the 2.3.4.4b strain, which is the one that we are discussing today. So one is that there's tons of H5N1s out there. It's not just one type. Some are more prevalent in one part of the world, some are more prevalent in others. The introduction to the US is relatively recent, in the mid-2020s, well, I think 21, 22, right? And it's relatively a single or very closely related strains, right? But there's a lot of activity all over the world, mostly among birds, but also among mammals. This I have to show because I'm sure no one in the audience have ever been to Antarctica. I never been to Antarctica. Well, flu has been there from the beginning, right? This is a scientist here going through Antarctica. Great job. And to culture animals there to see how much H5N1 is there. And they found that 22%. So 1 out of 5 animals are positive for H5N1. So it's been there for a long time, and it's basically prevalent there, and it continues to spread from there. And it was prevalent already among penguins, which are birds, and seals, which are mammals. So the spread has gone beyond just migratory birds to basically affecting other animals. So what's going on in the US? Well, H5N1 was first detected here in April 2022. So we're relatively late comers into this pandemic, right? But it's already here, right? And was detected in Colorado. First, among wild birds, there was a die-off of birds. Then when they went to check for that, they found that it was not only on wild birds, but also on backyard poultry, right? And then one human who was involved in culling these birds, then he got infected. So that was the first case. Of course, didn't stop there. And now there's been like thousands of outbreaks described in the US, basically affecting every single state, including ours. And millions of birds have been affected between wild birds and domestic birds. Millions and millions of birds have been affected and have been killed to stop the spread of the disease. Then in March 2024, so about 2 years later, that's when it was detected in cattle in Texas first, right? And that's what actually brought the attention to the general public about this problem. The veterinarians have been working on this, and the public health people have been working on this forever, but to the common public became a problem when in last year, in March 2024, it was detected in cattle and affected. There was cattle that were sick, they were not producing good milk, they were checked by the veterinarians, they were swabbed, and then all of a sudden they found they have flu, it's H5N1, and the genotype is 2.3.4.4b, B313, right? Interestingly, affects mainly dairy cattle, not beef cattle, because again, it tends to go to the mammary glands and tends to come in the milk. We don't know how this cattle were infected in the first place, and we know how it's being transmitted from one to the other. We learned that there's a lot of movement of this cattle from state to state due to the complex providing this milk to people. So that's how it's moved from one herd to another herd, but how it's transmitted from one animal to the other is not clear. The most likely explanation, because it's 10 times more, the viral load is 10 times higher in the milk than it is in the respiratory secretions. So the best guess is that when people are milking these animals, they're basically transmitting from one animal to the next one and to the next and to the next and so on. So by now it's probably close to 1,000 herds that have been affected in 17 states, and probably this is going to continue to grow. Interestingly, they are infectious 2 weeks before symptoms, so people may already be transmitting this from one to another before even realizing. And again, it's more frequent in the milk than in the respiratory secretions. And that's simply because, again, the milk, the other is the one that has the 2 receptors, while the respiratory secretions have only the human receptor and not the bird's receptor. Sure enough, a few months later, about 6 months later, then the first human case was detected, this time in California in September 2024. By now, there's been 70 cases in the US, 4 has been hospitalized, and there has been one death. Interestingly, the more severe cases and the hospitalized cases and the death are related to poultry more than directly to cattle, and it's due to D11 and not B313. Actually, the 2344B genotype, which is the one affecting the cattle, seems to cause a mild illness, mainly conjunctivitis, not too much more than that. So most cases are very mild, while the D11, which affects poultry mainly, that's the one that tends to cause more lower respiratory infections in humans and cause more problems. So there's no human-to-human transmission as far as we can tell yet. Every case has been all related, well, most of them have been related to exposure to dairy cattle, but there's a few that have no, especially pediatric patients. There's at least 2 pediatric patients where there's known exposure. Of course, children normally don't tell you what they've been doing, so as far as I can tell, they don't know how these kids got the infection in the first place. And of course, they sent people to figure out how extensive the problem was. They did some culture. They found that 64% in herds that were affected, they found that 64% of the milk, so 2/3 of the milk being produced in those places are infected with H5N1. When they swabbed the cattle, they found it only 2.6%. So again, it's less frequent in respiratory tract than in the milk. And actually, none of the workers that were asymptomatic had evidence of infection. They did other serial surveys. In one, they found that 7% of workers that were asymptomatic did have serologies that showed that they had been exposed and they had H5N1, even though they didn't know that. And a study among veterinarians who served these herds, they found that 2% maybe have serologies, even though they are asymptomatic. So there may be some mild asymptomatic transmission between humans, but again, the problem is among the dairy cattle. Reasons to panic, yeah, there's quite few. One is that it has moved from migratory birds to backyard flocks, so they're closer to humans, and they have moved into mammals, wild mammals and domestic mammals, which again come closer to humans. In the farms that are affected, they have cattle, and the cattle is affected. It's been found among cats and rats who live in that farms. They are infected and they get very sick, actually neurologic problems and so on, and they can die. But also domestic cats from people who work in these dairy farms and they come back home. The cats are not in the farm, but the person works in the farm, comes back home, and apparently transmit that to the cat. These are people who they swear they leave their clothes, which they work outside. They don't bring it to the house. Yet somehow the cats got in there. The thinking is the cats just lick the boots that have been, contaminated with milk because they like the milk, and that's how they're getting infected. But it seems to be very damaging to these cats, and we'll see if that causes a problem. FDA, interestingly, went to retail stores, got some pasteurized milk and checked if there was any evidence of H5N1 in those, and they found that 20% of them had H5N1, right? But the culture was negative, right? So that tells you 2 things. Tells you that the problem is pretty widespread when 1 out of 5, jars of milk that you get in the store have H5N1 there, but tell you that pasteurization works because none of them could be cultured, right? So don't drink raw milk. In February this year, H5N1 was found in New York in a live market, and it had to be closed and the animals disposed of. And then the market has been reopened once it was noted to be clear, but making it into, again, peri-domestic is around. Soon we will be in touch to them closer and closer. H5N1 has killed many mammals. Many of them are wild animals. So this may be a problem for hunters. If they get in contact with these animals, they may eventually get bird flu, H5N1, but also sea lions, seals, and dolphins have been affected. These are mammals, marine mammals. There's no case of whales yet affected, but I don't see why that could not happen. You know, whales migrate down here during the winter, sorry, and at the same time, all these migratory birds from Alaska and Canada and the Arctic, they also fly down here. So there's a possibility that they may mix and they may affect the whales, and it would be a real disaster if at some point we see die-offs of whales in the coast of Hawaii. So that's something to keep an eye on for this coming winter. Hasn't happened this winter. We'll see what happens this coming winter, but there's a possibility of mixing them and then having a big issue. In Oregon, this year too, H5N1 was found in 2 out of 5 pigs in a farm that is infected, that had infected poultry, right? So that's why they went in and they checked them, and 2 out of 5 had the H5N1. And again, I remind you, we said pigs can have the two, the human and the bird receptors. So they could be co-infected with birds, with bird flu and with human flu if a human in that farm happens to be sick, and then the pig gets the two, and then the two reassort, and all of a sudden you get out a new bird flu, which is very well adjusted to transmit between humans and keeps the characteristic of being highly pathogenic. Then you have a big outbreak similar to the H1N1 that we had in 2009, but not a mild one like it was that time, but actually a serious one. And that's what keeps us all from sleep tonight. And then it has been detected in wastewater in many places. And we'll get to that in a second. You may or may not know, public health normally check wastewater as a way to basically pool the secretions from everyone in a large community and see if there is anything going on. We did that for COVID, we've done that for rotavirus, for many other illnesses, so they do that for flu too, and it has been detected many times. So, and it usually appears there before you see human cases. So finding it in wastewater tells you that there's H5N1 circulating in the community, hopefully to a low level, will never amount to much, but you don't know where is it gonna go. This is a fun fact. Some researchers in Scripps, La Jolla, California, took the original H5N1 that was found in Texas, and they started to introduce some mutations to see what would it take for them to become easily transmissible among humans. And they found there's one mutation that can make it be highly transmissible. So, you know, it hasn't happened in real life yet, but we know that bird flu is only one mutation away to becoming transmissible in humans. God forbid, if it catches that mutation, by mutation alone or by reassortment, then we're going to be in big doo-doo. And the other thing is there's been at least 2 separate introductions of D11. Remember, this is the poultry one that tends to be more pathogenic, right? It's been at least two separate introductions to dairy cows. So there's a possibility that we thought H5N1 into cows was a single accidental event, right? It seems it's not. Again, other bird viruses, flus can do that, and they are actively doing it now. Again, because there's so many birds and so many cows out there that it's happening. And at some point, the wrong mix may happen, and then we may have real problems. So all those are reasons to panic. Reasons for hope, well, the list is shorter, but I hope it helps. There's no cases documented yet among household contacts. So the few human cases, which have been mild, I emphasize, have not resulted in secondary cases. So this is not at this moment a transmissible or highly transmissible problem, but it has not happened, but it may happen again. As we said before, it's only one mutation away, which may happen tomorrow or may happen never, but we don't know if it may or not. Pasteurization of milk inactivates the virus. Pasteurization is normally done at 65 degrees centigrade for 30 minutes. Pasteurizing milk in 2 minutes inactivates the virus completely. So the normal process of 30 minutes more than guarantees that either if there was any H5N1 in that milk, it's dead. And there's no way you're going to catch anything. So always get your pasteurized milk, don't get raw milk. Cooking poultry also inactivates the virus. And still, the viruses are all sensitive to the antivirals, right? Your Tamiflu still works well. So if there is any question about that, you just put your patient on Tamiflu and it should work. Vaccines is a mess. I'm not going to spend too much time there because there's no vaccine available right now. There are vaccines that can be produced relatively quickly, but quickly means 6 months, 12 months. It's not going to be in 2 weeks. So if indeed there is an explosion of this virus and gets out of control soon, quickly, then it's going to take a while before we can catch up and have the vaccine. But there is a whole framework that will allow us to have a vaccine within a few months if the need comes. It has not been produced at this point. It's been produced by some companies in Europe and it's being purchased by some countries in Europe. The US has not moved into that yet. There's a vaccine that is available for poultry to try to stop this from spreading. The problem is that there are some trading issues there, and the economy would be severely affected, and that's why the government has not moved into doing that. So suffice to say that there is a plan for vaccines, but there's no vaccines at this moment. We would have to wait at that time to see when they're available. And there's some monoclonal antibodies, but that's a little too complicated, and I don't think it's going to make much of a dent on an epidemic anyway. So what's the situation in Hawaii? Well, it's not that bad, right? We are at the very, very, like many things, Hawaii is always late, but eventually catch up. November, it took us November, so the end of the year, instead of being at the beginning of the year like the mainland, it was at the end of the year, last year, when they were doing wastewater surveillance for this H5N1, and one specimen in Wahiawa was positive. They went to the community and started looking around to see if they could find something, and they found one backyard flock that was infected, right? And it was the 2344B clade, the same one that is affecting cattle, right? So probably has been brought by migratory birds. It has contaminated local birds, and now it's around. And the more birds that get affected, the more that we are in contact, the more increases the chances that at some point it may spill into human problem, right? And for wastewater detection, yeah, in Oahu was this November 2024 that I just mentioned. In Hilo has been found in December 2024. In Kauai, it was detected at very, very low levels that were first considered negative, but now are considered likely positive in December 11, 18, and January 2025. So the point is that it's out there. It's not a big problem. It's not a big level, but it's out there, and it may go up, right? Again, when next season new migratory birds come, if they come also contaminated and bring more, eventually we may have a more endemic problem. They tell me one wild duck was found infected in National Preserve. They didn't tell me, and they didn't give me any more details, and I haven't seen that published, by the way, anywhere. So I don't know how that was verbal communication. But what is true is that we haven't had any among cattle or among humans, in no cases. So for us at this moment, it's a problem of wild birds and maybe some backyard flocks. But still, we're at risk, right? I mean, we have migratory birds that love to come down to Hawaii all the way from the Arctic. So that's the chances that they will keep bringing over and over H5N1 and new versions of H5N1 until they give us the wrong one exist out there. It has moved from migratory birds. We have plenty of domestic and peri-domestic birds. I mean, running this morning, there were wild chickens all over the place. We have cattle, even though it has not been found infected. We have cats all over the place, even though they have not been found infected yet. Swine, boars, ducks, wild animals that people hunt and get exposed to are a problem, right? And even though they tell me drinking raw milk is, selling raw milk is illegal in Hawaii, it happens, right? No one knows the extent and no one knows exactly where, but some people do it either with their own animals or they get from neighbors and so on. So that may be a problem at some point. So we do have the elements that if they mix the wrong way, eventually may start a problem, right? And again, because we are an isolated island, once it happens, it's like being on a cruise ship. When there is norovirus, there's no way, you cannot run away. You just have to go through it. So we don't have too many escape routes if this happens to be a problem. What is being done? Well, there's a lot of surveillance going on, and they don't publicize it too well, but there's a lot of surveillance and using the One Health approach. So animals, people, and environment. For animals, wildlife, if there is a die-off, they need to know. So they go and they collect those animals and they test them. Same thing with marine animals. There's one poultry farm, they tell me, in Oahu that has agreed to weekly being checked for bird flu. And so far it's been negative. We hope it stays that way. And there's one dairy farm in Big Island. To that farm, they go only to see sick animals. So they're not producing good milk, then they go and check them. And again, that hasn't happened yet. So they are keeping their eyes open in where the problem may be. And if it surfaces, then we will know. Of course, like anything else in public health, once you see something, that's the tip of the iceberg. Probably the problem is already more widespread. And then, yeah, you may need to do more than just telling people be okay. In terms of people, they're monitoring ILI, influenza-like illness. That is tough to do during the winter when there's a lot of people who have an influenza-like illness. It's better probably during the summer. Actually, the 2009 H1N1 pandemic was noted because it happened during the summer. When flu was not supposed to be happening. So if this coming summer, you start to see people with respiratory illness, influenza-like illness, that may be a reason to contact the Department of Health and see if they need to be tested for H5N1. And they're also having an active surveillance among flu A hospitalized people. So severe cases of flu A, they want to have those specimens so they can be typed to make sure they're not H5N1. As far as I know, a few have been sent, but none has been positive. And environmental, they're doing the wastewater surveillance, as I mentioned before. And again, that's probably the way to have a better anticipation of when the problem is happening. So what we hope is your role, what to look for. Well, the level of alert in Hawaii at this point is low. So you don't need to do anything different, just be aware of the problem. Check for symptoms, influenza-like illness. If you have people with flu A, especially if it's severe or out of season, try to contact someone. You can call us, you can call the Department of Health, and then we can talk about what you may want to do. And especially, if possible, get a history of exposure, right? Do this person occupationally or recreationally is exposed to birds or mammals that may be infected, right? And if that's a possibility, then yeah, probably you want to make a phone call because that may put you on the papers. What to do for the patient? Well, if you do suspect this may be H5N1 because they are hunters and they now it's the middle of the summer and they're having symptoms like influenza and they test flu A positive and they're sick and they need to be admitted, yeah, probably that person you want to do. So you have to isolate them, put a mask on them, protect yourself using full PPE, especially if they're coughing. You want to do face shield, you want to do your gown and so on. Gather all the information about the symptoms, possible exposures, any lab test, was tested for flu, was it flu A? If it's flu B, it's not H5N1, but if it's flu A, could be. If it's already known to be H1N1 or H3N2, which is in the respiratory panel, then you're okay. But if you don't know, only flu A, which is what most people probably do, that's all. That's as far as your tests go, then yeah, you want to talk to someone. And then you contact the Department of Health, the disease investigation number, and I'll give you that number in a moment, and or infection control and prevention. If you're in your system, you have infection control, then talk to them too, because actually they can be very instrumental in talking to the Department of Health, doing all these things instead of you having to do all them. If you don't have them, then you have to call them. And then they're going to tell you if they think it's a good case, and they're going to tell you to get a specimen. There's no real Department of Health kit. They're going to ask you to get conjunctival, probably NP or OP or nasal aspirate from the person. If you have the equipment, you can do it. If you don't have the equipment, then either they can bring you the equipment to do it, or you may have to send them somewhere to do it, right? But probably the person need to be tested. The thing to remember is you want to do Dacron or polyester flock tip swab and put it in a viral transport medium. So don't do the cotton swab with the wooden shaft. It has to be Dacron or polyester flock tip swab. And then you put it in ice, and then they will pick it up. Department of Health will pick it up. They will do the test, and in 24 hours, you will have the answer. And what to tell the patient when you're sending them off, because most of them are going to be okay. They don't need to be admitted. If they need to be admitted, this will be in-house. But if it's from your office sending them home, tell them to isolate at home until the symptoms resolve, which is about 5 days. You start them on Tamiflu twice a day for at least 5 days. The recommendations tend to imply that you can extend that to 10 days. And then you prophylax close household contacts, right? But prophylaxis is usually once a day, but for this H5N1, CDC is recommending actually doing twice a day for 5 days. So basically treatment. It's not prophylaxis, it's treatment doses. And they should need to be under observation for 10 days. This is as long as they could still develop symptoms, but rarely do they. And again, at this moment, there's no vaccine or other interventions indicated. These are the numbers that you can call. In Oahu, 808-586-4586, and then for other islands. And yeah, feel free to keep these numbers for yourself. Give them a call. There's usually someone who answers. If you need to talk to us, ID here, just feel free to call us too. We can discuss the case and see what may be pertinent. What to tell the public? Well, don't panic yet, maybe in the future, but be aware. If you're gonna anticipate an exposure, let's say you're in your house and you find 3 dead birds in your backyard, try to protect yourself, put on gloves, or at least get a plastic bag and cover your hands, and then pick the thing and close it well, and then call the Department of Health to pick it up. Try not to touch dead animals, right? Especially children that may, in the goodness of their heart, they may want to help a little bird who is, oh, look at the little one, is dying, whatever, and no, that the animal is sick. So don't touch the bird. If needed, handle with gloves or plastic bags. Do not drink raw milk. That's very important. And again, they tell me that even though there's no statistics about this, seems to be more prevalent than people realize. And wash hands after touching any animal. You go to a pet zoo and touch animals, tell the kids to wash their hands immediately. Don't touch themselves. And there was actually a potential outbreak that some of the animals that were sick in Hawaii at the beginning had been in a pet zoo, I think a week or 10 days before, and there was a possibility of those people being exposed. Fortunately, there was no one got infected there, but that's a possibility. So if you see an animal, and you touch an animal, you want to wash your hands. I just want to make you aware, this is the web page for the DOH here, which is relatively good. I haven't been updated in the past 2 weeks. I've been looking at it and it's the same, but it has a lot of information about bird flu, including all the numbers that I just gave you. So you can pull them from there. Where is it going? Well, no one really knows. Could be nothing or could become a pandemic, right? Anywhere in between, right? My personal bias would be that it's been around for so long and hasn't mounted too much. I don't expect, hopefully, that it will jump and do much, hoping more than knowing. But on the other hand, it's probably a harbinger of more to come, right? What it's telling me is that flu is very active. There's a lot of flu out there circulating in animals, circulating in people, and sooner or later, one way or another, is going to get to us. So if not this be the pandemic, I think it's showing us how a pandemic will happen at some point, and we need to be ready. Are we better ready, after COVID? I'm afraid the answer is no. We are as vulnerable as we were then. So if it happens, then we, the doctors, will have to again be the ones to detect the cases, treat the patients, give all the advice, and help the community through the process. And hopefully it won't be as bad as other scenarios. So the take-home point is avian flu is not new, but it's spreading, affecting not just birds, but now mammals and humans. So it's getting closer and closer. We need close monitoring of this zoo pandemic. It's basically in animals, but it will jump to humans. And we're part of the animal kingdom after all, so it will jump to us at some point. If not this one, other similar will cause a pandemic in patients with symptoms and testing of flu A positive as history of exposures. And if flu A positive and history of exposure, then contact DOH for instructions. And do what they tell you. Protect yourself and others, and treat the patients with Tamiflu and their contacts with Tamiflu. Again, the risk is low at this moment, but the situation is fluid. In a month, in 2 months, maybe a completely different story. We'll have to see where it goes. Actually, I'm more worried about the winter, the coming winter, when the birds and the animals will mix again here in Hawaii, and then we may have a explosion of this problem. We'll see where it goes. And this is a bunch of references. You don't want to look at them. They're sort of complicated. I just gave you all the details. And I'm going to try to do just 5 minutes on measles, if you don't mind, because I've been getting a lot of calls about this, including just a few minutes before starting this presentation. I don't know how many.
That would be great. Thank you.
I don't know how many of you have seen measles. You can put on the chat, measles yes, measles not. I would be interested to know, but I assume some of you have not. If you have never seen it, you may not recognize. Most likely, you're not going to recognize it. If you have seen it, almost 100% you will recognize it, right? This is all figures from the Red Book. The patient that happened here a week ago, fortunately, the doctor that saw that patient had seen measles. One case, but she could remember vividly what it looks like, and she called saying, okay, this patient is coming for possible Kawasaki, but I think he has the measles. And she was right. Again, the more you can see, the more comfortable you're going to feel. It's the typical morbilliform rash. That's what is shown here, right? I mean, it's so typical that it has a name. Morbilliform means measles-like rash, right? And many other things, because we give so many vaccines and we don't see this too often, many other diseases can have a similar rash, EBV and so on, but it's a morbilliform rash, right? Which is a maculopapular. You can see different. It's not rounded. It's more irregular kind of shape, different sizes. It's usually not itchy. It's not vesicular. If it's vesicular, it's not measles, right? And basically starts on the face and then goes down. Now here is the Koplik spots, right? Which I show you, but don't go looking for Koplik spots, right? Koplik spots, first, they're very I mean, I've seen it maybe twice because someone told me this is Koplik spots. And I've seen a lot of measles, but only twice they show me something that said these are Koplik spots. I have to believe them, but I don't know. I don't think I could recognize it well. It's like, looks like, it's like red and then a clearing in the middle, right? Which looks like a whitey spot in the middle, right? And it's around the molars. No one has ever explained to me why is that, why they look like that, why it's located there, why it happens before the rash actually, and it's very transient, right? In 12 hours, it's gone. So I don't think you want to spend too much time looking for Koplik spots. It's mostly the rash, right? If you see something that you think Koplik spots, that's good, but because it comes before the rash, 2 days before the rash, you probably may not, at that moment, you're not going to think this patient has the measles, right? But more important, one is the rash, but more important than that is actually the three C's, right? The cough, coryza, and conjunctivitis, right? And the coryza is not just being, what is the word? Not just being congested, but actually being bloated, right? I mean, you can see, especially the kid in the middle, I mean, the lips are like swollen, the eyes are like swollen, the nose is like swollen, right? I mean, they look like they have had a real bad day, right? It's not just a little runny nose or something like that. And then the eyes, if you look at the eyes, there's not so much bulbar conjunctivitis like you would see with Kawasaki. This is more tarsal conjunctivitis. That's why the eyelids are swollen, right? So you usually have to invert the eyelid to look at that, and yeah, it looks all red, right? So some of them, when you look at their face, you don't realize they may or may not have conjunctivitis. You want to look under the eyelid. If you see those things, and they cough significantly, right? They have a good cough. If you're there 15 minutes and they haven't coughed, that's not measles. They're going to be coughing like every 2 minutes. They're going to be having a real good, very congested, very wet kind of cough. So if you see that, if they're coughing, they have conjunctivitis and they have coryza, right? Not just, again, congested, but they really have coryza. And then the rash, yeah, then that's measles until proven otherwise. So that's what you're looking for. And then what to do with that? Again, this is all from the Red Book. Is three tables. We don't have time to go over all them, but basically you either do vaccine if they can get the vaccine, and you know the vaccine is technically after 12 months, but you can do it even starting at 6 months, but not less than 6 months. And in the first 3 days after exposure, right? After exposure. After exposure, if it's more 4 to 6 days after exposure, then the vaccine is not going to be in time. So you don't bother doing that. Then you have to do the immune globulin, right? Immune globulin is not easy to give. It's not easy to obtain. It has to be given IM, but the volume is such that actually after a year or 2 years, they just outgrow the immune globulin. You cannot give them immune globulin anymore. The volume is just not large enough. And then you have to either do nothing for them if they're immune competent, or give IVIG if they're immune compromised or if they're pregnant, right? The main thing for you guys is you want to make sure you are immune to measles, and you are immune to measles if you were born before 1957, which I don't expect too many of you are, or you have received 2 doses of documented doses of the vaccine, MMR, or you have serologies, right? And usually for medical school or for employment, they do serologies. So if you have proof of serologies that you had IgG to measles, then that's fine. By the way, measles is called also rubiola, right? And rubella is called German measles, right? I don't know when they're going to change that terminology because it's as confusing as it can be. One thing is measles, one thing is rubella. And actually, I've seen people, so they tell me, no, I'm not immune to measles. I have rubiola, but I don't have measles. It's the same thing. So they should get away with those terminologies. And yeah, so if you have a case or a suspect case, again, feel free to call us, to call the Department of Health, the same numbers that I gave you before, and discuss the case. The case that we had here is not related to the cases going in the mainland. It was from international travel, which is most of the situations in the US. What happened in Texas is that it was introduced internationally, and then it has a spread in the community, which low immunization rate. They tell me Maui has very low immunization rate for MMR. I heard 38%. That's terrible. If that's the number, then that's awful. It only takes one person, one traveler coming either from the mainland or from abroad and bringing measles to Maui, and then they're going to have an explosion of cases. If anything, a lot of people are calling now their doctors trying to get more vaccine, which is good. So hopefully, I guess when people are scared, then they forget about certain bad things, and they just, now they accept whatever the doctor is saying. So use that opportunity to educate them about the importance of vaccine. But make sure you have the vaccine. Make sure your personnel has immunity. So that way, if by any chance you happen to see a patient, you don't have to worry about you or your personnel getting infected. If you're immune, you're okay. You don't need to do anything. Still wear an N95 mask, put the patient on isolation. The reason why some people ask, well, if I have immunity, why do I have to wear a mask? It's true. Theoretically, you don't have to, but in practicality, you do, because the vaccine is not perfect. I mean, there's always a chance on whatever number that you may lose your immunity and then you may get infected. So you don't want that. So even so, as an extra precaution, it's a good idea to always do. And plus, you set an example, right, to your personnel and to other patients that, yeah, we all need to put on a mask. So anyway, go over these tables. Again, the Red Book has those, and they're very good. And I'm going to go over them and call us if you have any doubts, and then we can talk about that. And I think I'm leaving 5 minutes for some comments or some discussion questions if you guys have any. Thanks for your attention.
Thank you so much, Dr. Begue, and thank you for taking the time to speak about measles at the end as well. I'm not happy that it's heading in that direction with measles. I'm glad, at least as much as we spoke about bird flu a few weeks ago, it hasn't gotten as much worse as our measles numbers have, at least. Summer, do we have questions to go over in the poll? Maybe we can start working on that. And Renata did have a question asking if there's any difference in how measles present if you were vaccinated but still get the infection. Would that look the same in regards to symptoms, or is there something else to consider?
Yeah, that's a good question. It's milder, right? So if you have had at least one dose of the vaccine, or if you had two doses, but let's say it was 50 years ago and your immunity were down, as long as you're immune competent, it should be milder.
I'll just let everyone go through the poll questions quickly, and then we can go.
Okay. True or false? H5N1
Oh, wait,
avian.
don't tell us the answers yet. I still have the rest of the participants are still giving their answers.
Oh, people still, okay. Gotta wait for them to give their answers.
Little while.
Yes.
A few minutes. A couple minutes.
I have only seen measles once, and that was in residency when we had in 2014, I think, when we had a patient that came from visiting the Philippines, 11 months old, that had been exposed there. And I think that patient managed to go to multiple emergency departments or urgent cares and saw their pediatrician until it was finally diagnosed. So that was quite the treasure hunt of trying to hunt down all the exposures afterwards.
Yeah, the other thing I wanted to emphasize is the first, well, not the first case, but a case that I saw when I was a fellow was a child who came as Kawasaki, and this patient that was here also was sent with Kawasaki. So they can look very similar to Kawasaki. They have a rash, they have conjunctivitis, they have fever for a few days, and so on, right? So you want to be very careful with those cases. Uh, Actually, when I was a fellow for a while, we implemented a rule that everyone with Kawasaki should have a measles titer scent. Um, so that's, if anything, that's what it's going to look like. But again, soon you're going to see the difference. The rash is a little different, the conjunctivitis is a little different, and the congestion, the coryza is different.
Mhm.
But that's what, from most people have experience of seeing Kawasaki. That's sort of, but not exactly.
And especially here in Hawaii, we're so used to Kawasaki. It's, it's
Yeah.
always on the top of our mind.
Yeah. So every case patient you see with possible Kawasaki, think, am I sure it's Kawasaki? I'm sure it's not measles. Okay, then at least by now, until we dodge this bullet.
So things get under control a little bit more. Thank you so much, Dr. Begue, and thank you for everyone who joined us.
Mahalo. Thanks, everyone.
Thank
Thank
you.
you. Thank you. Bye-bye.